Okay, so we are talking about diagnosis and measuring the control of metabolic control of diabetes in today's lecture. So since you've learned your etiopathogenesis of diabetes in the I'm not going to talk about it, but if you have any questions, you can ask me anytime. Okay. So the first few slides are on the description and etiopathogenesis. So I'm going to quickly skip those things and go straight to the diagnosis. So you know, diabetes is a condition that where you have insulin deficiency or insulin resistance causing high blood glucose levels in patients. Okay. So these are the classifications. You learned everything, but I'll leave the slides. If anybody want to refer them, they can do that. Okay, type 2, other specific types, how the body maintains glucose control actions. Okay, and then shall I quickly go through the pathophysiology just for you to sort of recapitulate what you learned in your previous lecture with Dr. Sangwadi. So these people either have insulin deficiency or insulin resistance. So they don't have the action of insulin, which drives glucose into the tissue cells and giving energy to the metabolic processes occurring in the body. So the blood glucose, so what they have is therefore they have increased levels of glucose remaining in the circulation. Okay, and similarly, because they don't get glucose into the cells, they have increased hepatic gluconeogenesis and glycogenolysis, all contributing to hyperglycemia. Okay, when the blood glucose level exceeded a certain threshold, what we call the glomerular threshold, these glucose pass in urine, causing glycosuria. Glucose is automatically active substance. So when the small plenty of blood goes beyond a certain point, that causes osmotic diuresis, which lead to loss of lot of water as urine. Okay, this can contribute to pre-renal renal failure, causing reduced GFR. Okay, and they will have severe dehydration and hemoconcentration if the sort of the hyperglycemia is acute and severe. Okay, and at the same time, because of the lack of insulin, you learned this before, they have lipolysis leading to ketone body formation, which can lead to ketoacidosis, and they have protein breakdown causing muscle wasting. Okay. So we have identified certain criteria to diagnose diabetes. So we just don't use glucose levels or any other test which are above the normal or reference interval for a population. Okay, so yes, if we take a certain healthy population, they have a range of normal glucose level, but we don't use that to diagnose diabetes. We have developed certain other cutoff levels or criteria to diagnose diabetes. Okay, we can use HbA1c or plasma glucose level, fasting plasma glucose level, or 2-hour plasma glucose level after a glucose load. Okay, or sometimes even random glucose levels can be used. So these are the cutoff as shown in this slide. So if you do a HbA1c level, glycated hemoglobin level, if it is more than 66.5% or more than 48 millimoles per millimole, so this is expressed in both ways. Okay, both using both units, but this is the more preferred unit nowadays because we are going towards the SI units. If the HbA1c level is more than 65, that is indicative of, suggestive of diabetes. Similarly, if the fasting plasma glucose is more than 106 26 milligrams per deciliter, or in SI units more than 7 millimoles per liter. That is again diagnostic of diabetes. And fasting is defined as no calorie intake for more than or equal to 8 hours. So usually we fast overnight. 8 hours is enough. We don't recommend going beyond 14 hours of fasting, because then people tend to have sort of low and low glucose levels. So roughly 8 to 12 maximum of fasting, or maximum 14. Okay, and during this fasting, they are not allowed to eat or drink, but they can take a little bit of water. Okay. Then 2-hour plasma glucose cutoff is more than 200 milligrams per deciliter, or 11.1 millimoles per liter, after giving sort of giving a 75 gram anhydrous glucose. Now this test we name as oral glucose tolerance test. Okay, so where we give 70 grams of anhydrous glucose. You remember that because glucose can exist as molecules with sort of water molecules bound to glucose, monohydrous or dihydrous, like that. Okay, the 75 grams should be anhydrous, where you don't have any water molecules attached to the glucose. Okay, so when you buy the glucose, well, when you advise the patient to buy the glucose, or when you weigh the glucose, you have to find out whether actually this is anhydrous glucose. If it is monohydrous, you can do the calculation and give the correct weight. Okay, so this test or GTP has to done according to the procedure described, given guidelines. Okay, we don't always use random plasma glucose, but if the patient has very obvious symptoms of hypoglycemia, or if they are in a hypoglycemic crisis, as in ketoacidosis or hyposmolar coma, we can use the random glucose if it is more than 11.1. That the patient is likely to have diabetes. Now, if the clinical symptoms are very clear and the plasma glucose or the HbA1c is very high, maybe we can diagnose diabetes with one testing. But most of the time, we advise repeating the test. Okay, you have to be advised doing a second test. Okay, ideally it should be the same test. It's like if you did the HbA1c before, the second repeat testing also should be HbA1c using a new blood sample to confirm whether the patient has having hyperglycemia. Okay, not use HbA1c and plasma glucose. So it has to be the same test if possible. But for some reason, if you had to do 2 different tests, like first time fasting plasma glucose and second time HbA1c, and you get 2 discordant results, one says the patient is likely to have diabetes, one says not, then you have to again repeat the testing. The test that you should do is the test that gave you the results higher than the cutoff. Okay, say for example, if you got HbA1c of 7 and fasting plasma glucose of 10.8 millimoles per liter. Okay, so according to the plasma, not 10.8, fasting plasma glucose of say 6.5 millimoles per liter, because cutoff is 7. So according to the fasting glucose, the patient doesn't have diabetes, but according to the HbA1c, he has diabetes. So what you have to do is repeat your HbA1c and see whether you get the high results again. Okay. So again, I told you so many times, these testing have pre-analytical, analytical variability. They can differ, like if just near the cutoff, it can fall either on either side, diabetes or non-diabetes side. So depending on the clinical symptoms, you may decide to wait and watch. But if the repeating testing produce values below the diagnostic points, but you have clinical suspicion if there's family history, other risk factors. What you have to do is follow the patient closely and repeat the testing after several months, maybe 3 to 6 months. And then we also talk about categories of increased risk for diabetes. So they don't have diabetes, they haven't developed diabetes yet, but they have higher risk of developing it later. We also call this pre-diabetes. Okay, so that is when these testing levels are below your diabetic cutoff, but above that, higher than a normal healthy person. Okay, so if you do a fasting blood glucose, okay, fasting plasma glucose, and if it falls between 100 and 125 milligrams per deciliter, or 5.6 to 6.9 millimoles per liter, that is a pre-diabetic state. So he hasn't developed diabetes because it's not 7 yet, but he has higher risk of developing diabetes. Okay, and similarly for the OGTT, it is the levels are between 140 to 199 milligrams per deciliter, or 7.8 to 11 millimoles per liter. Okay, and for A1, what happened? For A1C, it is 5.7 to 6.4%. Okay, so these are the levels that the patient are at increased risk of developing diabetes. Okay, so there are guidelines developed by American Diabetic Associations for screening people. Screening is where you test people before they develop the symptoms, before they develop the disease as such. Okay, now because this screening is recommended because diabetes is a major healthcare problem. A lot of people nowadays have diabetes, get diabetes, has a high prevalence. Okay, so according to ADA guidelines, testing for type 2 diabetes should be done in all adults who are overweight or obese, that is BMI is more than or equal to 25 in sort of West. So this is American guidelines in white Americans, or more than 23 in Asian Americans. So they have lowered the cutoff for Asian Americans because Asians are at higher risk of developing diabetes than whites. Okay, and if they have additional risk factors. Okay, so you should screen people for type 2 diabetes if they are overweight beyond a certain BMI. Okay, plus they have additional risk factors. Okay, so testing, they recommend testing should begin at the age of 45 years. Now screening, you don't usually do screening before that, but after 45 years, if the patient is obese and have the following risk factors, they should be screened for diabetes. So these are the risk factors. So almost anybody can fall into that actually. Physical inactivity, restricted relatives with diabetes, high risk ethnicity, against like Asians are at higher risk. Okay, and so on. So this is the list of risk factors that you should bear in mind to screen for diabetes. So now these are the Sri Lankan guidelines developed some time back. So now we are a higher risk ethnicity. Okay, Asian dark skinned people have higher risk for developing diabetes. So Sri Lankan guidelines recommend screening starting at 35 years. Okay, whenever there is an opportunity, whether they have risk factors or not. If a patient comes to the hospital for something else, you better do a screening test, fasting blood glucose or HbA1c or whatever the screening testing to detect diabetes. Okay, even if they don't have risk factors. But if the patient is less than 35 years even, you should be doing screening in people with risk factors. Okay, so again the risk factors are more or less the same list as before. Okay, so you can use the same test for pre-diabetes testing also. Okay, now it's like for diabetes and pre-diabetes, the testing is the same. It's the cutoffs or the limits that are different. Okay, HbA1c, plasma, fasting plasma glucose, so 2-hour postprandial plasma glucose after a 75-gram OGTT. Okay, if tests are normal, so you should not, you need not retest before usually 3 years. So you test the patient again after 3 years. Okay, if the patients fall in the pre-diabetes range, you identify that, look for other risk factors like cardiovascular risk factors, and then if necessary treat them or try and advise the patient to reduce the risk factors. Okay, and testing to detect pre-diabetes or even diabetes should be considered in children and adolescents also if they are overweight or obese, and if they have risk factors equal more 2 or more risk factors. So even in younger younger people, children, adolescents, if they are overweight, you should consider testing for diabetes. Okay. So this is the sort of given criteria to test for diabetes or pre-diabetes in children. Okay, so it's more or less the same. I'm not going to go through them one by one, so slowly read that. Okay, so now you diagnosed patients. Okay, we're using your laboratory testing, and then if you diagnosed a patient with diabetes, you treat them. Okay, you may give lifestyle advice, you start treating, trying to get the glucose level down, but you have to monitor these patients very regularly to make sure that maintain a normal glucose level in blood all the time. Why? Because if they persist, they are anyway, whether they sort of control or not, these people are at higher risk of developing a lot of complications. Okay, they could be microvascular and macrovascular complications. I don't think you did the lecture yet, but you will learn in the later lecture. Okay, now if your glycemic control is very good, the rate of developing these complications are very slow. Okay, so you can have a normal life, but if not, these complications will develop very quickly, and you will have the patient will have a lot of morbidity and mortality. So the microvascular complications are small vessel disease, ischemic heart disease, peripheral vascular disease, cardiovascular disease. Oh, actually I have done the other way. Okay, these are macrovascular diseases. Microvascular diseases are retinopathy, neuropathy, and nephropathy. I'll correct that before I upload. Okay. To prevent these complications happening, or rather to delay these complications happening, you have to have very good glycemic control in the patient. So how do we monitor whether the patient is having good glycemic control? Is by doing the same test. It is either HbA1c or fasting or postprandial plasma glucose. Okay, but HbA1c measures the long-term glycemic control. Okay, HbA1c is glycated hemoglobin. So your hemoglobin molecules bind with glucose in a non-enzymatic reaction. Okay, so these bound glucose to hemoglobin remain the whole lifespan of the red blood cells. What is the lifespan of a red blood cell? Roughly 120 days, isn't it? So you, by doing the HbA1c, by measuring the sort of glycated hemoglobin level, you can assess the patient's glycemic control or blood glucose level control over these 120 days, roughly we say 6 to 8 weeks. Okay, so that not exactly 128 days. So you measure the long-term glucose control by doing HbA1c. If you do a fasting plasma glucose or postprandial plasma glucose, it's the sort of current, very short-term control at that moment glucose level in the plasma glucose. Patient may have very good short-term glycemic control, but may not have a good long-term glycemic control, which can lead to, if the patient doesn't have a good long-term glycemic control, they are more prone to develop, they can easily develop the complications of diabetes. So what is very important is to maintain a good glycemic control over long term, but in the patient management, we use the short-term monitoring tests as well. Okay. So these are the glycemic targets when we treat non-pregnant adult patients. Okay, if we measure the HbA1c in a patient with diabetes, we should maintain it less than 7% or less than 53 millimoles per millimole. Okay. Fasting plasma glucose or premeal glucose should be this. Okay, if you do the laboratory results. Okay. Now people do this glucometer testing at home or even at the ward sometimes. So if using the glucometer values, these levels should be more maintained roughly 3.5 to 5.5 millimoles per liter glucose level. Okay, and the cutoffs are like this for 2-hour postprandial plasma glucose. Okay, so these are the rough targets that you should maintain in a patient with diabetes. Okay, but it may vary from patient to patient depending his other comorbidities and complications and treatment complications. Okay, so more or less stringent targets may be applied to different patients. Okay, you can apply very strict targets like even HbA1c less than 6.5% in certain group of patients. Okay, so if the patient hasn't had diabetes for a long time, and if it is a young patient who has a long life expectancy, so you want to minimize developing complications. And then if he or she doesn't have significant cardiovascular complications, you can apply very strict glycemic control. Okay, the problem with strict glycemic control is patient can go into hypoglycemia, which is actually more fatal than having hyperglycemia. So that is the problem. That is why you can't have very strict glycemic control in some patients. So in those patients, the cutoff will be raised maybe to less than 8%. If for example, like patients who develop frequent hypoglycemia or severe hypoglycemia in the past, if the patient is quite old and has limited life expectancy, if the patient already has developed advanced microvascular or macrovascular complications, and have other comorbidities, and of course if the patient has had long-term diabetes, and in some patients it's very difficult to achieve a good A1C target, so you may sort of not try and reduce the HbA1c level drastically in those patients. Okay, so hold on a second, somebody. Somebody asked, is it hypo or hyper? Is it in this slide? Now, when you're treating patients with diabetes, the big problem is they're developing hypoglycemia. Okay, so because when you give insulin or hypoglycemic drugs, okay, because we are trying to bring the blood glucose level down, these patients have a high risk of developing hypoglycemia with the treatment. Okay, so the problem is now when you set your targets to maintain HbA1c targets, you have to bear that in mind. If you give higher doses, with large doses of insulin than necessary, they can go into hyperglycemia. If you give higher doses than necessary of oral hypoglycemic agents, again you can develop hypoglycemia, which is actually more severe than hyperglycemia. Hypoglycemia can kill a patient very quickly. Hyperglycemia is not so. Okay, so you have to balance your treatment and targets because of that. Okay. Somebody asked, Madam, why the targets are more stringent in patients without vascular complications. I think, this is like as in young patients, we want to prevent developing vascular complications. So, they are sort of morbidities, comorbidities, sort of prevent you giving very, very strict targets because they are at more risk of developing hypoglycemia. Okay, so you want to prevent complications. They are at a lesser risk of developing hypoglycemia. So we can apply strict targets for those people. Okay. So how frequently we should be testing these people who are on treatment? Okay. We, in the sort of, as soon as you diagnose a patient, we usually do short-term monitoring testing, fasting plasma glucose, or 2-hour postprandial. So ideally, once you start the patient on drugs, they should be done fortnightly, fasting and or postprandial, okay, until you achieve the desired glycemic control. Okay. Then after that, once you achieve the desired control, you can monitor monthly, either with fasting plasma glucose or postprandial glucose. That depends on sort of certain guidelines, clinical clinicians' preference, and so on. Okay. If you can't do both, they say it's better to do the postprandial glucose level after a main meal rather than the fasting plasma glucose. Okay. If the patient is on insulin, their plasma glucose level should be measured twice a week. Okay, because they are at higher risk of developing hypoglycemia. Sort of you need more frequent monitoring. Okay, and then to assess the long-term control, you do the HbA1c. It should be done every 3 months until you achieve the desired control target level, and once after that you can do every if the patient is stabilized on certain level, you can do HbA1c level every 6 months. Okay, so the blood samples we use for this testing for glucose, whether it's fasting, postprandial, is the glucose that we measure. Okay, we use the sugar tube, what we call the sugar tube, which has sodium chloride and potassium oxalate. So I've told you the sodium chloride in the tube is to stop the glycolysis, because glycolysis can happen inside the tube in the cells. Okay, if that happens, your the glucose level in the blood sample goes down, goes below than it was in the patient's body. So you won't know the exact glucose value of the patient. So you want to stop glycolysis happening in the tube. So that is why we use sodium chloride. Oxalate is, of course, for the anticoagulation. Okay, and then so you have to send the glucose in a correct bottle. And for the HbA1c, it is whole blood, because we measure the hemoglobin level. Okay, glycated hemoglobin level. So we need whole blood. We lyse the cells and measure the glycated hemoglobin level. So it should be set in the EDTA blood, the EDTA tube, which is the tube we use for full blood count. Okay, so the patient don't need to fast for HbA1c, or they don't need any special preparation for HbA1c. Okay, now if the patient has diabetes, there are other parameters that should be monitored regularly, because they are at risk of developing so many complications. So they are at risk of developing renal failure kidney disease, so we need to monitor their renal functions regularly by doing creatinine and EGFR. Okay, so they are at higher risk of developing cardiovascular diseases, so we should be doing regular lipid profiles. Mind you, the lipid profile should not be done every month. Okay, this is what we see in our practice. If they are normal, once a year is enough. Okay. Even in a patient who is on treatment, if the control is okay, you don't need to do it every month or every 2 months, 3 months. Okay. Then again, they develop renal failure. First, what they develop is proteinuria, so you have to detect proteinuria in these patients. Now, to catch early proteinuria, we do the test called microalbumin levels in urine. Okay, so it's the same albumin level. I think I have told you, or maybe you will learn more in our renal function test lecture. It's the same albumin level. Okay, it's not a different albumin, but with this method, microalbuminuria method, we can measure very small amounts of albumin passing in urine. So we can catch patients early when they are just developing the renal disease. Okay, so we do microalbuminuria if they don't have already, if they haven't already developed overt proteinuria. Okay, proteinuria you can detect by dipstick or protein to creatinine ratio in a laboratory. Okay. So if the patient has developed proteinuria, there's no point wasting money doing microalbuminuria test. So that is a sort of rather expensive test. Okay. Then we should measure blood pressure to assess again cardiovascular health. Annual retinal screening. So they are at risk of developing retinopathy. Okay, microvascular disease, retinopathy. So you should do annual retinal screening. And then they are at risk of developing neuropathy. So you should do foot check, foot reflexes, sensation, vibration sense, and skin for signs of pressure, ulcers, and so on to assess. So you have to look for all the complications developing before they properly develop in these patients and prevent them or stop them at the early stage. Okay. Okay. Then little bit of self-monitoring of blood glucose. Now, when you diagnose a patient with diabetes and when you put them on treatment, you frequently ask them to monitor their glucose level at home, okay, using glucometers. Okay, so because glucose levels frequently change with their diet, exercise, changes in lifestyle. Okay, so it's better if the patients can monitor the levels at home and keep a record and bring them to the clinic, and then maybe sometimes if the patient is educated, they can change their insulin levels on their own. Okay, so that is what is called self-monitoring of blood glucose. Okay. So this allows patients to evaluate their individual response to treatment and whether the required glycemic targets are achieved. Okay. And it is also now, so these people most of the time, if they are well educated, bring the records in, daily records in, so the dietitians can guide them with their nutrition or diet plan, nutrition therapy, physical activity, and the clinicians can look at them to see whether they develop hypoglycemia during any particular times of the day. So it's easy, and you can adjust the medications in very useful way if the patients do this. Okay. So these are particularly encouraged in patients receiving multiple doses of insulin or insulin pump therapy. Okay, you give insulin by pumps also. So they sort of advise doing glucose levels at certain times. So to check when they have hyperglycemia, when they have hypoglycemia. So using that, they can adjust, the clinicians can adjust the treatment. Okay. Okay. And how do we diagnose gestational diabetes mellitus? So this again, you learned what is gestational diabetes. That is diabetes developing during the gestation after pregnancy. Okay, that is in the second or third trimester of the pregnancy, which was not clearly over diabetes before the pregnancy. Okay, so usually in our patients, pregnant patients, we do testing for diabetes or for the glucose levels at the first prenatal visit. Okay, if they are not, if their blood glucose levels are okay at that time, okay, that means they don't have over diabetes or sort of non-gestational diabetes. Okay, if they had high blood glucose level, that they are more likely to have non-gestational diabetes if they have the high glucose level in the first prenatal visit. Okay, if this becomes, or this glucose levels returns as normal at the first prenatal visit, then they are screened for gestational diabetes at 24 to 28 weeks. Almost all the pregnant females in Sri Lanka, we do that. Okay, so if the cutoff levels are above the given cutoffs or given guidelines, then at that point we can diagnose gestational diabetes. Okay, so the screening is at 24 to 28 weeks. Okay, and then the patients who had gestational diabetes, or women who had gestational diabetes, should be checked again for again like 6 to 12 weeks postpartum after delivering the baby, to see whether they have persistent diabetes after the pregnancy, because they are at people or women with gestational diabetes are at higher risk of having persistent diabetes after the pregnancy also. So they should be, you can't just forget about the diabetes after the pregnancy. You should make sure that they have or have not diabetes after testing at 6 to 12 weeks postpartum. Okay, using a OGTT. Okay. So at that point, the diagnostic criteria that should be used is non-pregnant adult diagnostic criteria. Okay, so if at that point, if the results come below the cutoff points, then the patient is not having diabetes. You can sort of, you have to follow them up, because they are at higher risk of developing diabetes in later life. But you don't need to continue treatment. If the levels are beyond a certain cutoff point, above a certain cutoff point, then you have to continue treatment and monitoring as a diabetic patient. Okay. So as I said, women who had a history of gestational diabetes should have lifelong screening at regular intervals, like say every 3 years, because they are at higher risk of developing diabetes or pre-diabetes later in the life. Okay, and they should be advised or given lifestyle interventional therapy, or sometimes metformin to prevent development of diabetes. Okay, so you have to advise them to change their lifestyle to delay developing diabetes as much as possible. So as I said, screening for diabetes or gestational diabetes is usually done at 24 to 28 weeks. Okay, so we can do it in 2 ways. Diagnosing or the screening can be done by using one step 75 gram OGTT, or there's a 2-step method where you give 50 gram glucose for a non-fasting woman, and if this result comes as above a certain cutoff point, we will see that later, then we go for the 100 gram OGTT. Okay, so I think we have that. Yeah, so one-step strategy is gestational pregnant women at 24 to 28 weeks. we do the oral glucose tolerance test with anhydrous glucose. Okay, 75 gram anhydrous glucose. You give dissolve 75 gram anhydrous glucose in around 300 milliliters of water and ask them to drink that within 5 minutes. And before that, we take a fasting blood glucose, and then after the glucose load, we measure glucose levels at 1 hour and 2 hours. Okay, so we measure 3 glucose levels fasting, 1 hour after the glucose load, 2 hours after the glucose load. And these are the cutoff points we use to diagnose gestational diabetes. Okay, if any of these cutoffs levels, if any of these levels are beyond these cutoffs, you diagnose gestational diabetes mellitus. Okay. In the two-step strategy, now you know pregnancy is a very difficult thing. You get a lot of nausea, vomiting, even reflux. So it's not easy to drink this glucose load. Okay, and it's not easy for them to fast even. Okay, because it's difficult for pregnant people, if they prefer, they can do a non-fasting. The patient is asked not to fast. They are given a 50 gram glucose load, okay, and measure the blood glucose level 1 hour after that. And if the blood glucose level comes more than 140 milligrams per deciliter only, then they are sort of considered as having higher risk of having diabetes. Then you go for 100 gram OGTT in this patient. If the levels are below this, you consider this patient as unlikely to have diabetes. Okay. If it is more than 140, you go for 100 gram OGTT, where you give 100 gram anhydrous glucose load to the patient and measure glucose levels 1 hour, 2 hour, and 3 hours after that. Okay, and you take a fasting before the glucose load, and these are the cutoff levels to diagnose that. Okay, so you can either adopt one step or two-step theory, step strategy to diagnose gestational diabetes mellitus. Okay, so I think that's the end of that. So you have to know the procedure for GTT, because you have to advise patients to do this properly. Okay, please go home. I mean, you are at home, of course. Please find the correct procedure for OGTT. I told you roughly, but on your own, find the procedure for OGTT, and you can ask any questions anytime. Okay. Now that is the end of the first lecture. I will post the recording. Still to go. Okay. Now the next part is acute complications of diabetes. Okay. This is just a little bit of epidemiology to show you the importance of diabetes. Now there are a lot of research going in the world because this is such a prevalent disease. Okay, to find out new treatment, find out new ways of management. Okay. So when we talk about complications of diabetes, there are chronic complications which can be microvascular or macrovascular, which you will learn in a later lecture. But we are going to talk about today is acute complications, and then there could be other complications like they are more prone to develop infections and so on. Okay. So the acute complications that a diabetic patient can develop are mainly 4 of them: diabetic ketoacidosis, hyperglycemic hyposmolar state. Okay. Earlier it was called hyposmolar non-ketotic state. Okay. And then they also can develop lactic acidosis, and they can develop hypoglycemia. Okay. Diabetic ketoacidosis is where these patients with diabetes, especially type 1 diabetes, people develop acidosis with ketonemia, ketone bodies in blood. Okay, they have a mortality of 2 to 5%. 100% patients come in with diabetic ketoacidosis, there's a risk of 2 to 5 patients die. Okay, these many deaths occur because there's a delay in presentation and initiation of treatment. So they are at higher risk of dying if they present late or the treatment is delayed. Okay, elderly can rarely present with ketoacidosis, but usually not. But they have a higher mortality if they develop diabetic ketoacidosis. Okay, mostly type 1 diabetic people, as I said, are affected by ketoacidosis because their insulin levels are very, very low. Okay, so incidence is around 5 to 8 per 1,000 diabetic patients per year. Okay, and 25% of them are patients with newly diagnosed, so they are almost presenting with diabetic ketoacidosis before sort of diabetes really is diagnosed. Okay, so their presenting feature is ketoacidosis. Okay, and as I said again earlier, very rarely it can be seen in people with lean type 2 diabetic patients. Okay, now the pathogenesis is, diabetes, especially type 1, developed because there's progressive beta cell failure in the pancreas, leading to deficiency of insulin. Okay, so in previously undiagnosed patients, type 1 diabetes patients, they can have severe insulin deficiency, leading to development of ketoacidosis. Okay, in patients who are already diagnosed with diabetes, okay, if they omit their insulin dose, or if they are not taking adequate insulin doses, okay, or maybe during a superadded infection or any other illness like gastrointestinal illness, trauma or stress or treatment failure, so their demand for insulin is higher, their stress level is higher, so they can precipitate diabetic ketoacidosis. Okay. So what they have is very low levels of circulating insulin levels in the blood, and because of that, increase of counter-regulatory hormones such as glucagon catecholamines. Okay, so this leads to catabolic changes in the body, all the catabolic processes you learned: carbohydrate metabolism, fat metabolism, protein metabolism. So this leads to a catabolic state in the patient. Okay, so as I said, they have very low insulin levels and the carbohydrate metabolism. What happens, as in any patient with diabetes, they have all these problems with their metabolism: reduced glucose uptake, increased glycogenolysis and gluconeogenesis, leading to hypoglycemia and glycosuria, polyuria, dehydration, as I said. Now, all these things are happening, and when it is sort of more acute, you develop ketone bodies. Ketoacidosis is because development of ketone bodies. That is mainly because of lipid breakdown of adipose tissue, lipolysis. So when there's low insulin levels, lipid metabolism, lipolysis is increased, causing breakdown of adipose tissue, which release a lot of fatty acids, which generate fatty acids, and these fatty acids go to the liver and undergo fatty acid oxidations, causing formation of ketone bodies. Okay, when the ketone body levels are increased in the blood, we call it ketonemia, and these ketone bodies, then these ketones then pass in the urine, causing ketonuria. Okay, so that is why how they develop these acetone smell during breathing, because the ketone bodies, there are three main types: acetone, acetoacetate, and beta hydroxybutyrate. Okay, so you get this acetone smell in the breath. Okay, and then you have protein breakdown as well, but the ketoacidosis is mainly because of this pathway. And it can lead to nausea and vomiting. Ketonemia causes nausea and vomiting, which aggravates polyuria and dehydration. And so for the diagnosis of diabetic ketoacidosis, we do glucose levels, we do arterial blood gas analysis, and we check for ketone bodies. Okay, usually they have very severe hyperglycemia, could be even more than 13, 14, 15. Okay, and but lower levels can, even at lower levels, they can have diabetic ketoacidosis. Okay. Acidosis we detect by doing arterial blood gas analysis. Okay, if the pH is less than 3.5, we say it is acidosis, and their bicarbonate levels are also low, very low. And then there are methods of measuring ketone levels in blood or urine, and if they have any ketone bodies in the blood or urine, then they have ketonemia or ketonuria, and they have acidosis, so we say, and they have hyperglycemia, so we say diabetic ketoacidosis. Okay, so this is the pathway of ketogenesis, which you have learned so many times, just for you to go home and revise. Okay, and then we can measure the ketone bodies using urine strips. Okay, so something like this. Okay, there are methods of measuring ketone bodies using strips. Okay, the problem with that is now these strips, or even your Rothera strips you learned in your biochemistry, mainly measures acetoacetate and acetone. I said there are three types of ketone bodies in the body: acetone, acetoacetate, and beta hydroxybutyrate. Okay, these methods mainly measure acetoacetate and acetone. But in diabetic patients or in ketoacidotic states, actually what is more is beta hydroxybutyrate. Okay, so when you measure the ketone levels in urine using a strip, you may not detect a severe ketonuria. Okay, so that is sort of a limitation in this testing. Okay, then you have to if available, you can do the blood ketone body levels. There are specific blood beta hydroxybutyrate measuring tests, which is not again easily available to us. You can do that, or you can sort of use your clinical guidance to do that. And in these patients, something else also happens when you start treat them with insulin. This pattern reverses. Then the acetoacetate and acetone levels goes up, and beta hydroxybutyrate levels reduces when treating. Okay, and then now once you started treating the patient, the ketone urea becomes positive, which was negative when the patient is having severe symptoms. Okay, so that you have to remember when you interpret these results. So you have to always be cautious and be guided by your clinical findings. Okay, and then there's another problem with the ketone bodies. Now these people with dehydration, vomiting, or spotting diuresis are at higher risk of developing renal failure. And so you will expect a high creatinine levels in these patients, but ketone bodies also can interfere in this testing, causing falsely high creatinine levels. So again, you are at a problematic stage. Whether this high creatinine is due to high ketone bodies, or whether it is due to interference, or due to real renal failure. Okay, then again you have to discuss with the lab. Maybe they can find another method of measuring. There are other ways of measuring creatinine, and always be guided by your clinical team. Okay, let me see this one question, I guess. Okay, I'll answer that later. Okay, so this is the Rothera's test for ketone bodies. I think you have learned this in your biochemistry time in second MBBS. Now the same principle is applied in the strip as well. Okay, we hardly do this on test tubes nowadays. Okay. And the other thing you have to remember is ketonuria is seen in other situations as well. Now, ketone bodies can be produced in body in starvation, severe vomiting, right, in some inherited metabolic diseases like glycogen storage disorders. Okay, so it is not always because of diabetes. Okay, so you have to again take into account your total clinical picture, other investigation findings before deciding this is diabetic ketoacidosis. Okay, so as I said, diabetic ketoacidosis is precipitated. I mean, not all people with type 1 diabetes get diabetic ketoacidosis. There has to be some precipitating factors which demands for more insulin or more sort of metabolic compensation. So things like infections, if the patient is not taking treatment, inappropriate changing of insulin doses, uh, other sort of illnesses like myocardial infarctions can precipitate diabetic ketoacidosis condition. Okay, and of course, in type 1 newly diagnosed patients, sometimes because they are not on treatment and they go sort of diagnosed at the beginning and they have severe insulin deficiency, they can present with diabetic ketoacidosis. Okay, so they more or less have the same clinical features as in severe hyperglycemia. You can work out with the pathogenesis of these algorithms. And in addition to other features, they usually have this small breathing, deep regular sign breathing because of the high ketone levels in the body. Okay. And they can have other biochemical abnormalities associated with ketoacidosis. They usually have hyperkalemia, okay, but there's a total body deficit. The total body potassium levels is low because they lose a lot of potassium in urine. So when you start treating these people with insulin, insulin drives potassium into the cells and they can go into hypokalemia. So you have to most of the time give potassium with insulin when you treat these patients. They also can have hyponatremia, high triglycerides, urea because of the renal failure, high phosphate, high magnesium, high amylase levels. There's this sort of disturbance to the pancreatic functions. All these things can lead to these abnormalities. Okay. Okay, I have a sort of quiz which I use usually in the normal lecture hall. Let's see whether look at a lecture until I answer this. Look at this sort of case, sorry. Can somebody, sorry, hold on a second. Okay, these are the investigations. Okay, try and find answers for the questions. I need answers. So what is the probable diagnosis? Now we had been talking about it all the time. Yeah, somebody says type 1 diabetes, somebody said diabetic ketoacidosis. So yes, as you can see, there's acidosis because H plus level is high. Okay, so there's very high glucose level. What was the history like? Wait a second. 14-year-old boy found by the mother drowsy, thirsty, abdominal pain. Okay, hypertension. Okay, so he has deep sighing respiration. Okay, so he has high urea. Okay, high potassium, low sodium. So yeah, I mean this doesn't say anything about ketonemia or ketonuria. Okay, but he's most likely, since he's having acidosis, since he's having high blood glucose level, he is likely to have diabetic ketoacidosis. Okay, this is a young patient. Okay, so how would you confirm this quickly? By doing a ketone level, the blood or urine. Okay, so most probably it will be positive. Okay, so he most probably he will have high ketonuria or ketonemia levels. Okay, so how do you treat these patients? What are the principles when you go to sort of treat these patients? You have now, there are problems in this patient. You had identified high glucose levels, so you have to treat that. Okay, you have to lower your glucose levels. Yes, and yes, principles of treatment. So you manage your glucose levels. What else? You hydrate the patient. Yes, because he has high urea levels, most likely to be is losing a lot of water from the body by means of diuresis. Okay. Yes, you treat the acidosis. Okay, you try to bring down the H plus level. Okay, you correct electrolytes with caution. Now, when if it is acute, you have to be very careful when controlling your electrolytes. Okay, and monitor them. Definitely, you have to monitor them. Okay, for ketone bodies specifically, we don't usually do anything. It will be resolved on itself when we treat the other conditions. Okay, good. Okay, now the next acute complications is hyposmolar hyperglycemic state. Okay, it is usually more sinister than DKA and have a higher mortality because it usually affects middle-aged or elderly patients, and it is usually not as acutely developed as in DKA, as DKA has a more insidious onset. Okay, and most of the time it is mistaken for other conditions like stroke. Okay, it's not very sort of easy to detect clinically. Again, the precipitants are like infections, okay, use of certain drugs, and some other medical conditions, actually stroke, cerebrovascular accidents, subdural hematomas, other infections, inflammatory conditions can precipitate this hyposmolar hyperglycemic state in a patient with diabetes. Okay, so again, the diagnosis is more or less similar. It's a biochemical diagnosis. The patients have severe hyperglycemia, high serum osmolality. Usually, their serum osmolality level is much higher than in DKA, and they usually don't have acidosis or ketonuria or ketonemia. Okay, so they have very severe hyperglycemia with high osmolality. Okay, and they can have the same features: hypernatremia, hypokalemia due to water loss. Then they can go into coma. Okay, sometimes they can have lactic acidosis or mixed acid-base disorders, and because of the high osmolality in the blood, have a risk of developing thrombosis. Okay. So we see this mostly in people with type 2 diabetes, elderly people, and 2/3 of the cases can occur in previously undiagnosed diabetes. Okay. Again, as I said, in addition to things I said, ingestion of high sugar meals or high sugar drinks can be a precipitating factor. Why they don't get ketonemia or ketonuria is because these type 2 patients usually have certain amount of insulin in their body, in their blood. Okay, so they are not insulin deficient. They are more insulin resistant. So this insulin level they have is inadequate for glucose utilization by the tissues. So they develop hyperglycemia. But uh, they have sufficient amount of insulin to prevent lipolysis and ketogenesis. So that is why they don't develop ketonemia or ketonuria. They don't have ketoacidosis. Okay, so they have enough insulin. They don't have enough insulin to sort of maintain the glucose level, but have just enough insulin to prevent lipolysis and ketogenesis. Okay. What's the question? Let me see. So that I think I just explained the pathogenesis of HHS. Okay. They also can sometimes rarely develop lactic acidosis. This is a condition where the blood lactic acid levels goes beyond a certain point, causing acidosis. It's acid, so it causes acidosis. Okay, but they don't have ketone body level, high ketone body levels in the blood. So any condition with impaired oxygenations can any person, I mean, even without diabetes, you can develop lactic acidosis if there's impaired oxygenation of tissue, as in hypoxemia, shock, sepsis, and so on. Okay, and some medications like metformin, fenformin can precipitate lactic acidosis, and that is where sort of these diabetic patients are more at risk of developing lactic acidosis. So these are 2 types of lactic acidosis that can occur in anybody. So these elderly diabetic patients can develop lactic acidosis as well. Not very common. Okay. The most life-threatening and the most common complication is hypoglycemia. Okay, so that is actually as clinicians, as doctors, we should bother more about hypoglycemia than hyperglycemia, because a patient can die within minutes if they develop hypoglycemia. So the detection cutoff level for hypoglycemia is roughly defined as less than 3 millimoles per liter, but this definitely varies between individuals because different people's response to different glucose level, low glucose level is different. For some, it may be 3.5, for some it may be 2.5. Okay, so for example, a patient with very high blood glucose levels all the time, a diabetic patient, might experience symptoms of hypoglycemia at a higher level than a normal person or someone with very good glycemic control. Okay, so for them, this could be even 4 millimoles per liter. At 4 millimoles per liter, they can experience symptoms of hypoglycemia. Okay, so in a diabetic patient, what are the conditions that can lead to hypoglycemia? So they are definitely on oral hypoglycemic drugs or insulin, so which can lower your glucose levels. So if it goes beyond the desired levels, they can go into hypoglycemia. While on the treatment, if they don't the patients are strictly advised on their diet while on insulin, special insulin and oral hypoglycemic drugs. While on treatment, if they don't take food as they used to do, they can go into hypoglycemia. So if there's an imbalance between food intake and insulin intake, there's a risk. Okay. If the insulin is usually given as a subcutaneous injection, by mistakenly or because of negligence, if it was given as an IM injection, it is absorbed rapidly and they can go into hypoglycemia. Okay, and even having a hot shower or warm bath shortly after injection, insulin injection is thought to cause increased insulin absorption, which can lead to low glucose levels. Again, exercise, which is more than normal, alcohol and other drugs, increased duration of diabetes. Okay, anybody who have a increased increased duration of diabetes and non-treatment are at risk of developing frequent attacks of hypoglycemia. And there's something called impaired awareness of hypoglycemia, which we'll be discussing later. And if the patient suddenly goes into a dieting, slimming diet while on the treatment, then the risk is more. If the patient develops something like vomiting, the risk of developing low glucose is more. So in a patient with diabetes who is on treatment, there are so many things that can lead to hypoglycemia, especially when his usual lifestyle, diet and exercise is and with the balance of his treatment is not done in the usual way. Okay. So in anybody, these are the causes that can cause hypoglycemia. Okay, not a diabetic patient. So there are so many causes that can cause hypoglycemia, not related to diabetes. So even in a diabetic patients, you have to remember that these also could be a cause for hypoglycemia. So you have to know these things: some drugs, some insulin secreting tumors. Okay, in alcohol, some gastric problems, adrenal insufficiency, hormonal problems can lead to hypoglycemia. So if you can't find a cause for hypoglycemia related to diabetes, you always have to think of other causes as well. Okay. So the signs and symptoms of hypoglycemia are not very specific, but usually are categorized into two different things: autonomic symptoms and neuroglycopenic symptoms, as listed in here. As you can see, I mean, we say sweating, confusion, tiredness, and so on can be symptoms of hypoglycemia, but usually it's more sort of personal experience. So these symptoms differ from patient to patient. Okay. So there's something known as reduced hypoglycemia, glycemic awareness, which develop in diabetic patients. Okay, so in these patients, they don't. I mean, in a normal patient or in a diabetic patient in early who has not this stage, they can feel when they develop hypoglycemia. They get these symptoms. Anxiety, sweating, they have those symptoms. Okay, so in these patients with reduced hypoglycemic awareness, they don't realize that they are developing hypoglycemia. Okay, so they don't get these warning signs of hypoglycemia. It is because their autonomic nervous system is damaged due to microvascular disease or microvascular complication. They have neuropathy. Okay, so the problem is if they are not aware of the hypoglycemia, they don't take action about it. So they don't take any sugary drink or sugary food. So they go into severe hypoglycemia, and they are at higher risk of developing severe hypoglycemia than the other people. Okay. And so according to the research, it is found that 25% of people with type 1 diabetes will be unable to recognize the onset of hypoglycemia. This is reduced hypoglycemic awareness, which usually develop in type 2 diabetic patients due to long-term diabetes and neuropathy. Okay. This is what. Okay, so if you have increased duration of diabetes with tight glycemic control and in addition to neuropathy, you can have that condition. So what you have to do is, like, you educate the patients, you sort of prevent patient going into hypoglycemia by advising him to take frequent meals and without giving the chance to the body to go into hypoglycemia. Okay. And there's another thing called nighttime hypoglycemias that can be seen in diabetic patients. Okay, so they usually wake up in the night or early in the morning with a headache or hangover-like feeling with very high blood glucose levels. Okay, so this is like a rebound hyperglycemia. which occurs in the night. Okay, so if you test blood glucose levels during these times, they will be very high. So usually it's sort of early hours in the morning, 2 to 3 a.m. Roughly, which is sort of, if you test them, most likely to detect hypoglycemia. Okay, this you can uh, uh, sort of resolve by changing your therapy timing of insulin or oral doses. Okay, type of insulin, maybe the long-acting insulins, okay, or long-acting drugs. You can sort of usually have to adjust your treatment regime in these patients to prevent these attacks. Okay, and having a long-acting snack also can help in these patients. Okay, just one slide about insulinoma, because that is sort of a common thing we talk about when we talk about hypoglycemia. This is a pancreatic tumor which occurs in the pancreas and causes and secretes insulin. Okay, so these people present with frequent episodes of hypoglycemia. It's very difficult to identify at the early stages. Okay, now when we test, what we detect is high insulin levels, because it secretes insulin, and high C-peptide levels, which is sort of the binding molecule in insulin molecule. Okay, so you know this is an insulin molecule. It has an A chain and a B chain, and this is the C-peptide. Okay, so if in these patients the C-peptide level is also high, but if a patient with insulin given because he's diabetic, okay, comes with hypoglycemia, if you do the C-peptide levels, we don't detect high C-peptide levels, because in the synthetic insulin that we give as a drug don't have this C-peptide part of the insulin. Okay, so synthetic insulin has only A and B chains, no C-peptide. So we don't detect high C-peptide levels in people who take insulin as a drug. Okay, I think that's the end. Yeah. Okay, look at this case as well. 50-year-old male diabetic using metformin. So what is this? So there's somebody asked about nighttime hypoglycemia. I think I may have confused you. So they have hypoglycemia in the late night or early morning, but they sort of have a rebound hypoglycemia soon afterwards. Okay. So have hyperglycemia with a rebound hyperglycemia. Okay, so yes, this is hypoglycemic hyposmolar state. I think a lot of people have problems with the nighttime hypoglycemia. Okay, so this so they sort of wake up with the hypoglycemia. So wake up with the headache or hangover feeling because they got the hypoglycemia. Soon afterwards, they get a rebound very high glucose level. Okay, so that is what it is. Okay, hypoglycemia with a rebound high glucose level. That is why you see the high blood glucose level. Sorry about confusing you. Yeah, so the case is hyperglycemic hyposmolality state. That's why you don't see the ketone bodies in urine. Osmolality is quite high. And the treatment principles are more or less the same. You sort of treat the glucose levels and the dehydration, renal failure, and so on. Okay. Okay, and then there are questions. Why does acetone and acetoacetate increase with treatment? So that is, I can't remember the exact pathogenesis, but that is what happens in diabetic ketoacidosis. I think, can I remember it? No, I can't remember the pathogenesis exactly. I will find out and let you know. Okay, but in diabetes, when the ketoacidosis, usually it's beta hydroxybutyrate that is high, and it sort of goes down, and acetone increase when you treat them. Okay, it's sort of something to do with the pathway, how it goes. And then there's another question. Hypoglycemic unawareness is common in what type of diabetes? It can be seen in both the types, but mostly in people with long-term diabetes. Okay, because of the neuropathy, can happen in both. Okay. Yeah, sodium levels are high in this patient because of the diuresis and dehydration. It could be because of the diuresis. I mean, sodium is sort of could go in both ways, but this is here, it's mainly most probably because of the diuresis and dehydration. Okay, let me